Good afternoon, everyone. Today I would be presenting Pupillary Block following Nd YAG Posterior Capsulotomy laser for posterior capsular opacification, a case report. I have no financial interest to disclose. Pupillary block is a complication of Nd YAG laser posterior capsulotomy in pseudophakic eyes occurring immediately after the procedure or time after. It occurs due to disruption of the anterior hyaloid face and leakage of hyaloid across the edge of the IOL, which comes forward to block the pupil. It has been rarely reported in literature as capsular bag fibrosis around the hydrophobic acrylic IOL edge prevents a direct communication between vitreous and the aqueous chambers. So our case, a 48-year-old male patient presented with right eye pain and redness for the past 5 days after having undergone laser posterior capsulotomy elsewhere. It started as a severe pain radiating to ipsilateral hemicranium. There was a past history of phacoemulsification with hydrophobic acrylic foldable IOL implantation in the right eye 1 year ago and in the left eye 1 month ago. The general examination was within normal limits. The significant findings on ocular examination in the right eye, the IOP was 36 millimeters of mercury as measured by Goldman's applanation tonometer. There was 360-degree circumciliary congestion. The anterior chamber was shallow peripherally and mid-peripherally with a Van Herrick's grading of 0. 2+ cells were present. The right eye's pupil was mid-dilated and fixed. PCIOL was in the back posteriorly, but the edge was in the pupillary area and there was a lasered PCO. So all these findings, along with nothing obviously seen to be blocking the pupil, brought us to consider these differential diagnoses. So why it's a pupillary block? Because in pupillary block, the central anterior chamber depth is normal as the IOL is situated posteriorly. It's not aqueous misdirection syndrome because in that case, the whole iris lens diaphragm would have moved forward and the AC should have been uniformly shallow. In this case, we had not done an ASOCT or UBM, but if done, it will demonstrate vitreous in the anterior chamber or the pupillary plane in the case of pupillary block, whereas in aqueous misdirection syndrome, there will be a characteristic fluid in the suprachoroidal space under the ciliary body with anterior rotation of ciliary processes. On our B scan, we had got a normal B scan, whereas if it would have been aqueous misdirection, there would have been aqueous spikes in the vitreous. It's not hypertensive uveitis because the inflammation was not that much to cause an IOP rise. So a provisional diagnosis of pupillary block following Nd YAG posterior capsulotomy with stable IOL and good residual capsular support was reached. No aqueous pockets were evident on B scan and immediate management with acetazolamide 250 milligrams 2 tablets stat with frequent instillation of atropine eye drops brought down the IOP to 25 millimeters of mercury within 3 hours. And then there was a continuation of acetazolamide QID with atropine eye drops thrice daily and combination eye drops brimonidine plus timolol. So next day, the congestion had not decreased. The IOP was 27 millimeters of mercury. Central AC was still deep and the nasal AC was still shallow. So a follow-up at 5 days, again we saw an IOP rise to 42 millimeters of mercury. The hyaloid was found completely blocking the pupil. So intravenous mannitol 300 cc was administered. Nd YAG peripheral iridotomy was performed and a sudden AC deepening was noted. So tapering doses of topical prednisolone and anti-glaucoma medications were given. This brought down the IOP to 22 millimeters of mercury with relief of pain. These investigations were found to be within normal limits at this stage. The patient was called at 2 weeks but reported at 2 months. The IOP at that time was 28 millimeters of mercury. Hyaloid was partly blocking the PI. A second iridotomy was hence performed and again deepening of the AC was noted. 15 days later, the IOP was 14 millimeters of mercury. Hyaloid was still blocking the pupil as well as the first PI. Steroids and anti-glaucoma medications were gradually tapered and the patient has maintained an IOP of 20 millimeters of mercury ever since. Comparison of OCT RNFL of the left eye and visual fields was stable over 6 months. So pupillary block following laser posterior YAG cap. It's first reported by Rudderman et al. In 1983. The vitreous comes into the anterior chamber and causes an intractable IOP elevation. It's a diagnostic dilemma because refractive index of aqueous as well as hyaloid is same. It's the most frequent complication following laser capsulotomy is a transient rise in IOP, maybe due to an obstruction of the trabecular meshwork by capsule remnants, high molecular weight lens proteins and inflammatory debris. So in patients with pseudophakia, transient increases in IOP are seen at the rates of 29 to 50% on the first post-op day in eyes with pre-existing glaucoma. Various etiologies have been proposed. It could have been that increased IOP resulted in a damage to the trabecular meshwork. A similar case was reported by Kersey et al., who observed pupillary block following Nd YAG laser capsulotomy in a previously subluxated IOL. So minimal energy should be employed, 1 to 3 millijoules per pulse, and 4 to 5 capsulotomy should be created always less than the size of the optic. Capsulotomy should be directed more anteriorly in pseudophakic and aphakic eyes. We should take care of medications like apraclonidine and timolol and acetozolamide either 1 hour before YAG cap or immediately after the procedure they should be administered. Fixation of posterior chamber IOL should be in the bag. And in this case, a timely management with medical management, laser iridotomy, and a consistent follow-up helped us to prevent vision-threatening complications. These are my references. Thank you.